Hi everybody, welcome to this anatomy and scan demo of the respiratory muscles. I will be giving this demo together with my colleague Jeroen van Doorn. We're both from the Department of Clinical Neurophysiology in the Radboud UMC Nijmegen. First, let's start off with some anatomy. So these are all the respiratory muscles that we have. These are inspiratory muscles and expiratory muscles. Of course, the most important inspiratory muscle is the diaphragm, which accounts for approximately 70 to 80% of the respiratory work. Of course, we'll be scanning this one together with the intercostal muscles, which is an accessory inspiratory muscle, and we'll be showing some expiratory muscles, the abdominal muscles. So, but why would we want to scan these muscles? There are different applications when you would like to scan these respiratory muscles, and mainly they're scanned in the intensive care or in patients with neuromuscular disorders. So in the ICU, you can use it, for example, to diagnose respiratory muscle dysfunction, and it's primarily focuses on the diaphragm. For example, if the diaphragm may play a role in difficult weaning. And with respect to weaning, it is also used as a parameter to predict weaning failure. There are a lot of studies out there, and also some nice meta-analysis where you can look up all the literature on this topic. And it can be used to assess patient-ventilator interaction. And this is all nicely written up in a review from colleagues from Amsterdam, from Tuinman in intensive care medicine, which is recommended to read. And ourselves, we've written a review about the application of respiratory muscle ultrasound in neuromuscular disorders. Here it's used to diagnose respiratory muscle dysfunction. Primarily the diaphragm is scanned here, and it's a more sensitive tool and more sensitive tool to predict diagnose diaphragm dysfunction than other tools like needle EMG or chest x-rays. Important tool to use, and it can be used as an outcome parameter in for example, drug trials that are under studied. So first, let's start with the diaphragm. There are different approaches to scan the diaphragm. We'll be presenting the lateral intercostal view, and here you can visualize the diaphragm in the zone of apposition, and this is where the diaphragm attaches to the rib cage. And typically you can use a linear high frequency probe of at least 10 megahertz. And we always start at the 8th or 9th intercostal space to look for the diaphragm, but you may change this, for example, if it's a difficult view. And typically you start in the anterior mid-axillary line and you scan in B mode, and you can switch to M mode. I will demonstrate this. So let's start. We pre-recorded some demos. You can see here in the right bottom the position of the probe. So this is my hand, this is the subject, and you can see here the position for scanning the left diaphragm. And this is the actual image that you can see with two ribs that are visualized. You can see a shadow below the ribs because the ultrasound waves cannot look through the ribs. And between the ribs are the intercostal muscles. Then you have the diaphragm and then the abdominal space. So let's start. So you can see here a small or normal inspiration, and I can pause this inspiration, and then we can measure the thickness of the diaphragm. And you can see here that the diaphragm is 2.4 millimeters thick. Then I ask the subject to take a deep inspiration, so we can measure at total lung capacity. So you can see a deep inspiration, and you can see that the diaphragm thickness. And then I ask again for a deep inspiration, and you can also see the lung sliding in very nice. So here you can see the lung. So now I will freeze the image. So now it's frozen, and I scroll back in time till maximal inspiration. So this is here, you can see the lung, and you can see a really thick diaphragm. So it increases from 2.4 to approximately 7 or 8 millimeters. So this is a huge increase in diaphragm thickness. So this is how we measure the thickness at end expiration and inspiration. I also want to show how you can look in the intercostal space by rotating the probe. So again, I'll start the video. So now we have the ribs, and now I'm rotating the probe, which you can see here. So now it's rotated, and we're in the intercostal space. And you can see again the lung sliding in and the diaphragm moving up and down. Okay, the last video I want to show is here we have the intercostal view with the ribs that are visualized and the diaphragm. And this is in M mode. So I start the video. You can see here then between these lines is the diaphragm. And then I ask to take a deep inspiration, and you can see that there's an increase in thickness. And now you can measure end expiration and maximal inspiration in one view in the M mode. So it's here 2.5 millimeters, which is comparable to the previous measurement, and an increase in thickness to 6 millimeters. So sometimes this works, sometimes not, because, for example, due to movement, it's difficult, or when you have the lungs sliding in. Okay, so these were the demos. There are some important pitfalls when performing diaphragm ultrasound. For example, diaphragm thickness is different at different intercostal spaces, so you have to take this into account, for example, when you standardize your protocol, and of course the thickness varies at different lung volumes. And importantly in ICU patients is that mechanical ventilation of course affects diaphragm thickness. So a high support of the machine unloads the diaphragm and reduces diaphragm thickening. It's sometimes difficult to obtain reproducible images, so this also takes some experience and training to get a reproducible image, and it's important, for example, to mark the position when you're doing multiple images. And especially for diaphragms that are very thin, for example, in neuromuscular disorders, the resolution of the most machines is typically around 0.1 millimeters. So if the diaphragm is really thin, it becomes very difficult to take a good image. Okay, lastly, are there normal values? Yes, but there's a lot of variation between normal values. So in our review, we have a table with all the normal values from different studies, and also we've written down which approach there are. So you can look at these normal values. So typically it's about 1.5 to 2 millimeters thick, the diaphragm. So now I will be I'm ending this diaphragm scan demo, and my colleague Jonne Doorduin will continue with the presentation.
Thank you. I will be covering the accessory respiratory muscles, of which I'm going to cover the intercostal muscle first. You can visualize the intercostal muscle basically anywhere on the rib cage. But we choose to visualize the parasternal intercostal muscle, as this is of purely inspiratory action, in contradiction to the rest of the rib cage, where the intercostal muscles are of mixed inspiratory and expiratory action. What we choose to do is to position the ultrasound probe at the third intercostal space, 3 to 5 centimeters lateral to the sternum, and in B mode we can measure the thickness of the intercostal muscle. What you can see, if you position the ultrasound probe spanning 2 ribs, and in between the ribs is the intercostal muscle, and underneath the intercostal muscle is the lung. And what you can see if you tweak and rotate the ultrasound probe a bit, that this has a large effect on image quality. So you should find a position where you're happy with your image quality, and you can measure intercostal muscle thickness, which is in this case 2.5 millimeter. Then going on to the abdominal muscle, which are of accessory expiratory action. There are basically two views. In one view, we measure the thickness of the rectus abdominis muscle, and in the other, you can visualize the all three oblique abdominal muscles. First, to cover the rectus abdominis muscle, you place the ultrasound probe 2 to 3 centimeters cranial to the umbilicus, and you sweep laterally until you see the whole muscle. What's good to mention here is that the rectus abdominis muscle is portionated, and not only in guys who go to the gym a lot, you can have those portions, anyone has them. And those portions are vary in thickness, so you should find the thickest part of a portion where to analyze the thickness. And then if you sweep to the side, halfway between the iliac crest and the rib cage on the anterior axillary line, you can find the oblique abdominal muscles. And one good thing to mention here is that the fiber direction of those three muscles are not aligned. So no matter how you position the ultrasound probe, you can get only one muscle in which the fiber direction is aligned with your ultrasound probe. And what we do is that we measure the thickness individually for all 4 muscles on the B mode. And this is, I've decided to make a demo with all 4 muscles in one image. And you can see where we start a few centimeters above the umbilicus. And in the middle of the screen, you get the white line, the linea alba. And on both sides, you can see the rectus abdominis muscle. And if you play this, then you sweep to the side, you can see that the muscle is larger than the image screen. And if you move up and down, you can see the portion that it gets, the muscle gets thicker and thinner. So you freeze at the thickest part of the portion and you measure the thickness, which is 13.1 millimeters at this point. And then you sweep to the right and a bit lower, so caudal. And then you freeze again, as you can see, the external oblique abdominal muscle, the internal oblique abdominal muscle, and the transverse abdominal muscle. And you can measure the thickness of all 3 of them separately. You can also measure the thickness of them combined. But that is basically how we measure the abdominal muscle thickness. And that was basically what I wanted to show you about scanning the accessory respiratory muscles. I want to share, however, a few exciting developments in this field, of which the first is the quantitative ultrasound of the respiratory muscles, which is a grayscale analysis of muscular tissue as visible on ultrasound. And this quantifies fatty replacement of fibrous tissue, which is an enormous hallmark for neuromuscular disorders. Second, which is more known in the cardiac ultrasound application, is strain imaging. This can quantify muscle deformation during contraction, and this is expected to be lower in patients with a neuromuscular disorder. And a last exciting new possibility is shear wave imaging, which can be applied to the respiratory muscles. And this quantifies viscoelastic properties of a tissue. And all those modalities combined give a very good overview of the muscle in this regard to respiratory muscles. And that was the end of our scan demo about the respiratory muscles. I would like to thank you for your attention, also on behalf of Jonne Doorduin. And please do not hesitate to ask us any questions, and you can use this contact information to reach us. Thank you.